What if I told you that the biggest problem in rural health is not distance? It's not even road, it's not doctors, it's not the hospital, but what if I told you that the real problem is money? But not in the way that you may be thinking about it, because here's the thing, money is being spent, budgets are being announced, donors are pledging. You can see from Bill Gates' last pledge. Policies are being written. So why does a pregnant woman still have to choose between food and antenatal care? Why does a clinic exist but has no drugs? Why does an ambulance exist but never arrives? And why, year after year, rural communities remain at the edge of health systems that claim to serve everyone? This is Rethinking Rural Health Financing on What About Rural Health with Chinasa. I am your host, Chinasa Imo, and this series is not about numbers alone. It's about the power. It's about the priorities. It's also about policy. It's about who decides whose life is worth investing in, because financing is never neutral. Every budget tells a story. Every funding gap reveals a choice. Every unpaid health worker is evidence of a system that has decided it can wait. But for rural community, waiting is not abstract. In fact, waiting is dangerous. Waiting is bleeding. Waiting is lost. Waiting is death. So let's start with the simple question. Why is rural health always underfunded, even when everyone agrees it matters? Is it because rural people are smaller? Is it because they are politically quieter? Is it because their suffering is less visible? Or is it because our global health system were never designed with rural health at the center? Think about it. Most rural health financing models assume proximity to facility, proximity to market, proximity to infrastructure, proximity to power. But rural health is built on distance. Distance from hospital, distance from decision makers, distance from emergency response, distance from funding conversation. So when we fund health system without accounting for distance, what we are really doing is funding exclusion. We often hear phrases like universal health coverage, health for all, no one is left behind. But I want to ask something uncomfortable. Who exactly is all in this conversation? Because when health financing is designed in capital cities for urban population using urban assumptions, rural communities are always left behind before the first dollar is spent. And yet, rural communities are not passive. They improvise, they adapt, they are innovative, they survive, they're survivors. They fund health care themselves through out-of-pocket payment, community contributions, informal networks, and debts. So here's another question we don't ask enough. Why do rural communities pay most of the least care? Why does poverty cost more? Why is health care cheapest where income are highest and most expensive where income are lowest? Why does accessing free healthcare require transportation, time off work, unofficial fees, and social negotiations? And why do we keep calling this a service delivery problem when it is clearly a financing design problem? Because financing shapes everything downstream. It determines whether a clinic is built or abandoned, whether health workers stay or leave, whether drugs are stocked or rationed, whether care is preventive or purely reactive. Financing decides whether health systems respond to people or wait for people to arrive already sick. And in rural areas, waiting often comes too late. Now let's talk about donors. Because donor funding play a huge role in rural health, especially in the global south. Donor funding has saved lives, and I must recognize that. There is no denying the fact. But donor funding also comes with timelines, indicators, priorities, and exits. So here is my other question, and this one is very uncomfortable. What happens to rural health when funding cycle ends? What happens when pilot projects close? When grant expires? When program scales somewhere else? Why do rural community often become the testing ground, but rarely never the beneficiaries of long-term investment? And why is sustainability always discussed only after implementation is already done, rather than built into the financing from the start? So let's talk about that. And while we are at it, let's add cost effectiveness. But effective for whom? We talk about return on investment, but whose return counts? Is it economic productivity, political stability, demographic control, or is it human dignity? Because rural health financing often prioritizes what is measurable, not what is meaningful. What is meaningful means trust, continuity, community presence, and these are often the hardest to fund. I'm going to also pivot for us to talk about governments. Because government matters. Public financing is the backbone of equitable health system. At least it should be, and that is what my government's classes told me. But in many countries, health budgets fall far below commitment. And when budgets are tight, rural community is always the first to be deprioritized. Why? Because rural communities have less political leverage. Because urban crises are louder. Because rural suffering is normalized. We say it's always been like that. But always is not a justification. It's an indictment. So I want to ask, what would rural health financing look like if rural lives were valued equally? What if budgets were designed starting from the farthest village, not the capital city? What if financing followed people and not facilities? What if funding health workers to stay in rural community, not just to be trained? What if transportation, housing, security, and community trust were considered legitimate health investments? Because health does not happen in isolation. A clinic without a road is not a health care. A nurse without pay is not a solution. A policy without implementation is not a progress. And rural health financing must reckon with all of these complexities. This series is about asking the hard questions that we avoid. It's about unpacking why health insurance often excludes rural workers, why out-of-pocket payment persists, why community-based financing is underutilized, and why private investment avoid rural health, and why innovations struggle to scale outside the cities. But most importantly, why does rural health continue to be remained unattended to? Most importantly, I want to ask, who benefits from the way rural health is currently financed, and who pays the price? Because someone always pays. If it's not government, then it is the families. If it's not the system, then it is the woman. If it's not the system, then it is the communities. And that cost is not abstract. It is counted in missed appointments, it's a preventable death, is exhausted health worker, is the quiet resilience that never makes headlines. And in this series, we will be unpacking that, and we'll be speaking to policymakers, health economics, frontline workers, researchers, advocates, and the communities themselves, not to offer an easy response, but to confront this hard truth. Because when we begin to rethink rural health financing, it is not just about how money is moved. It's about moving mindset. It's about moving investment. It's about recognizing that rural health is not charity. It is justice. It's not an afterthought. It is the foundation of public health resilience. Because when rural system fails, epidemics will spread. When rural care collapses, cities feel it. When rural lives are undervalued, society fractures. So as we begin this journey, I will leave you with this question. If rural health systems were adequately financed, if care are accessible, affordable, and dignified, if distance were planned for, not ignored, what kind of world will we be living in? And more importantly, why aren't we there yet? This is Rethinking Rural Health Financing, and we're just getting started. Thank you very much. Listen to all of the episodes in this series. I promise you that you would enjoy every bit of it. Thank you, and bye.